Thank you everybody for attending our webinar on iVotion, which launches one of our digital denture solutions. Very excited to co-sponsor this with Ivoclar Vivadent. As you know, iVotion is a monolithic disc that will create a denture. As you can see in this, it has a pink and white disc where the teeth and the base are milled out together to make a very strong denture, and one that's when you're in compromised prosthetic space. So you can see in this disc, maxillary disc, where the denture has just been milled out, showing from the teeth, the occlusal view down to the base, and on the mandibular, the same perspective. You can see where the teeth and the base are milled out of the same disc. And then we take the denture out of the disc, and as you can see, that the gingival bases, gingival margins are all perfectly intact, even the lingual surfaces, the buccal surfaces of the mandibular denture, as well as the maxillary. The intaglio surface is really a really key part, because that's what makes the fit so precise and such superior fits. You can see how clean the intaglio comes out. And then the finishing process of the maxillary denture is very, very easy. Minimal time, 10 minutes or so to finish a denture. But the key to that is really everything is there. Very minimal things to do. Just finally going over, with the gingival margins and the contouring of the base, and then pumicing and polishing it. And this is what it ends up looking like. As you can see, digital dentures truly have arrived. The aesthetics, the fit, the function of digital dentures is truly there. And this is the denture that we want to offer to you, is truly the iVotion denture, from Ivoclar Vivadent, our monolithic solution. And there are other solutions where we split file, but today we want to concentrate on the iVotion monolithic denture. And as you can see from the full dentures, maxillomandibular denture has very, very good contours, excellent contours, gingival contours, interdental papilla, gingival margin. So looking at this, I would put this up against any conventional denture. But more than that, it's really the data you get out of this denture, and Dr. Lauciello will go into that in much more detail. So with this, I'd like to introduce my mentor, my colleague, and my friend, Dr. Lauciello. I've been truly blessed to get to know Frank over the years and work with him on a number of projects and lecture with him. And you're in for a real treat, because Frank's spent a number of years developing these products for digital dentures. And I think both of us, this has revitalized our life, just being involved in this digital denture revolution. So without further ado, my mentor, Dr. Frank Lauciello. All right, Frank.
Well, thank you very much, Rob. Am I unmuted and everything? Yep. All right. Well,
Audio,
I could
Frank?
argue. Oh, am I muted?
Oh, you're all good.
I'm good?
Yep.
Oh, great. Well, thank you very much, Rob, for the warm introduction. And as you can see from that picture of Rob and I, we kind of go back a long way. And not that Rob has changed much, but I think I have quite a bit. But anyway, what an honor it is to be here, and what pleasure to again work with Rob. I'm not sure about the mentor status. Who is the mentor? I think we kind of shared that platform back and forth between us, because I've learned so much from Rob. Rob did many master level programs in our education center, so I just have a fond relationship and respect for his capabilities. So here we are. We're back again, and looking at another phase of dentistry. And I chose this title, and I chose it kind of carefully, because it is a pathway. And there's a lot of options and a lot of stumbling on the way, perhaps. And I want to do whatever I can to help, especially for those of you who have not ventured into this digital technology, to try to help you with the transition into this process. It's a worthy transition. Rob was very nice to show a few slides on the beginning here, showing some of the mechanical aspects of the dentures. I want to assure you there's some clinical aspects to this that you must understand and must get familiar with, and hopefully experience. So it's a pathway and it is a transition, and we'll do all we can to try to ease this transition best we can. This is the basic outline, which we're going to try to get as somewheres in the middle here, because we're planning on probably having a part two with this particular program. It's a lot of information. So we thought we'd start, with the initial program and see approximately where the time element is. I don't want to take any more than an hour. It's about all my attention span I have and given a lecture sometimes, and certainly about the attention span that you have to listen to a lecture. So let's start with what we refer to as some of the technical advantages. And it's a fair question to ask. With all this technology, this CAD CAM and all this kind of hocus pocus type technology, could we make a better denture? It's a fair question to ask on the technical side. And as we look at the some of the basic advantages of the thing, and the answer roughly is yes, because this technology is unbelievable in the things that it could offer us in the way of the mechanics of the physical characteristics of the denture. The first is, and Rob kind of touched on that, is the accuracy. It's unbelievably accurate, and it's basically 100%. And look at some of this infinitesimal measurements here. It really does show that there's minimal distortion, for all practical purposes, zero distortion in the processing of these dentures, as opposed to, as best we could do in analog dentistry or traditional dentistry, even with the finest of the denture curing units. The IvoBase was by far head over heels over every other denture manufacturing, and even with that, still we're getting like a percentage or so of some distortion. So this is really a quantum leap in the right direction with accuracy. Strength, especially with this monolithic process, which we're going to get into a little bit more detail later, it's off the chart. It's a much stronger denture, and we could the obvious advantages of that is, the patient's less chance of fracture or denture. Now this becomes even more important in certain clinical workflows, such as a single arch denture opposing natural dentition. It's a very a challenging environment for a denture to exist in, because it's getting hammered at with teeth anchored in bone. Implant supported restorations, opposing that is very important, as well as the denture that's supporting the implants itself. So a lot of strength is a welcome change in physical properties. Uniform thickness, and it's not only a uniform thickness, but from this, as I mentioned, this technology, what it does, it follows the basic tissue contour and gives you exactly what you dial in. So if you dial in a 2.5 millimeter thickness, that's exactly what you're going to get in this denture base. But it follows the tissue contour. Why is that kind of interesting? Well, from the clinical perspective, patients feel this. They kind of come back with feedback, trying to explain the difference in their traditional denture compared to the digital denture. And part of it is because they say it kind of disappears in my mouth. I can't quite explain it. And it took me a while to understand what the patients were reflecting on. And it really was the fact that the tissues were following the contour of their tissue, as well as having the even contour. And that reflects to the patient, as it helps them make the denture like disappear in their mouth, and they would come out with those kinds of comments. So this uniform thickness is kind of a nice physical attribute of this process, but it has clinical implications for sure. And then right here we could see the best of technicians, even a Rob Cryer technician level, would have challenges trying to to do an even thickness of a denture base, because it's just virtually impossible to do in our traditional technology. So let's look at another factor. And what's really kind of nice with this technology is the arches are preset. In other words, if you select a tooth form, and it is available to the software in a complete setup, so that we could go from this stage of wax of a rim type of a relationship to a complete setup. We're going to get into a little bit more detail when we talk about setting of teeth, but having the arches preset by some of the world's class dental technicians. I hate to even call them technicians, or they're artists. They're above and beyond their capabilities of setting teeth, and they're set perfectly and really studied to be set greatly. So these are available to the laboratory, and what a wonderful start of setting the teeth to have the world's technical artists being able to help you with the initial proposal of setup. Having the materials pre-processed and industrially pre-processed is very important, because there's no there's a level of consistency and predictability in the material performance. So there's no guesswork. Gee, is the monomer polymer the right proportion or whatever, or the timing was it correct in the processing machine or something like that. So it kind of eliminates a lot of the potential errors with the pre-processed materials. So let's look on the clinical side, and this is where you and I and a lot of the clinicians who are in the program here are wanted to ask a few questions. And I guess the first question we have to ask, when I say we, it's me and the patient. I guess, wonderful that there's this great technology, and I see some advantages, but I guess I got to know what's in it for us. And that's not an unfair question to ask, for sure. I'm going to go through a couple of proactive things that could be done with this technology that you just can't do in traditional dentistry. And the one that jumps out, because the first thing I do is examine the impressions that are delivered. And again, the best impression that you've ever taken is never perfect, in that there's a little bubble here, a little blub there, a little artifact there. Not a big deal. You understand that. You try to, sometimes you see it and you try to make corrections on a cast. But with this digital technology being blown up to the size of the screen, we could really examine the virtual models, and you can identify little blebs that might need a little bit of correction. And these little blebs, if they're missed or not corrected or whatever, they could cause a sore spot, and it could actually be the cause of a sore spot visit, which is inconvenient for the patient and expensive for you. So doing a cast correction is a wonderful way of applying these tools and this technology. And what I didn't hear is this particular tool kind of identifies these little blebs, and kind of miraculously is a way of being able to average value their depths and make a little slight corrections without causing any major change in the impression. It's kind of a correction of the impression, not changes of the impression. So this cast correction is a very nice proactive ability of this technology, and something that could really save you some chair time. Prefabrication relief. This is an opportunity in each individual clinician or technician has a different feeling on this particular topic, where we could identify certain areas that we would like to have some relief prior to the fabrication. Some things that are common, and for me, on a personal note, I like to identify the incisal papilla and the median palatine raphe. I like to always put a little bit of a relief over there. Now, how do I do this in traditional dentistry? Well, you have to wait till the day of insertion, and I put some pressure relief cream, and usually you have to pick up these areas and then do some internal adjustment chair side. Well, I'm going to be proactive on this with this technology. This allows me to identify the areas that I would like to add, just again, minimal relief, but enough that's going to make a difference in the chair side insertion day. And what I've done here too with this relief, I've with this, again, the tools that are offered here will allow me to go into these little sharp crevices, and I could eliminate those with a little a relief material. And this is now going to be transferred over into the final denture. And I will guarantee you, done right, or at least with a conscious effort here, we're going to save sore spots adjustments and number of adjustments and the intensity of adjustments that are going to be necessary chairside. So this is a great proactive, and there's a way that you could get involved in this part of the process. I would, and certainly share on this ability to get proactively involved. The border extension, another very critical aspect of the denture. We take impressions, and yes, the impressions are a reflection of what we want our denture to look like. But until you really blow this up and examine it, and actually are going to have control on the particular border extension, this can be extremely effective, again, in a proactive way of controlling the extensions, and therefore the insertion and post-insertion is going to be influenced by this tremendously. One of the things we do in the traditional approach with borders, as you know, a little bit is good and a lot is better. So we're always overextended on the borders with the intent that yes, we could grind these back, and it's a very time-consuming procedure. And doing the denture border adjustments chair side is messy. I don't want to do it. I'd much rather be proactive in the design aspect and kind of control my peripheral border extension as opposed to adjusting it chair side. And by the way, with this traditional technique of having to grind these borders and things, it's another aspect of distorting your denture base. These burrs, especially if they're not sharp, could create a lot of heat and actually causes PMMA distortion. So a wonderful thing to be able to avoid with this new technology. Taking jaw records, I think, is our greatest challenge. I think we all pretty much kind of agree on that, and to some capacity. And with the digital technology, the bases that you're going to be working with, even the temporary bases during the interim procedures, are going to be highly accurate because the technology is, as I mentioned, it's very accurate technology. So your chances of getting a more accurate jaw record has jumped 100% because you're going to be dealing with a stable base in your process of trying to secure a inter-arch relationship compared to the traditional manner, and again, not knocking it, it's the way it is, the way it was, the way it is. We look at the master cast. We have to block out master cast, otherwise the temporary denture base may cause damage to the master cast. We don't want to do that, so you have to block it out, and sometimes a little icon down there in the bottom of the how these denture bases, sometimes they fit like a sock on a rooster, and they're not very retentive, and so that creates a tremendous challenge clinically, trying to balance these bases intraorally and stabilize them while you're trying to get a jaw record, like an accurate jaw record. So you can see how important the stabilized base is. And these bases, whether they're printed or milled, these interim bases are going to be so much better to work with clinically. And as I said, your chance of getting successful jaw records is greatly enhanced. Again, they're not blocked out, or they're fully representative of the cast that you want it to be. So that works. So processing, as we said, it is accurate. And you're going to notice this in the retention of the denture base, especially in the maxillary denture and the mandibular denture, by the way. You'll be surprised at some of the fits you're going to be getting on the mandibular denture as well. But the maxillary denture, I haven't done I'm so happy to say, I haven't done a mechanical post-dam in at least 5 years, maybe longer, since I've been doing digital dentures, and it's not needed. The traditional mechanical scratching of the cast and making this bead in the posterior part of the denture, we felt that was necessary because of the traditional inaccuracies of denture processing. And with the denture base lifting up, and we got a gap there. So the way to close the gap is to put a bead of material back there, and that's what the scratching of the cast would create, is this post dam of material. With the digital technology, not necessary. So it's a tremendous advantage. Equilibration, it depends on your schooling, I guess. In my background as a prosthodontic program director and working with my residents, it was just taken for granted that the day of insertion was the day that we take a what we call a clinical, the final maxillomandibular jaw record, and prior to the insertion of the dentures. So we got the final dentures, we put it in the patient's mouth, we take a bite registration, we take it in the laboratory, remount it on the articulator, and do an equilibration. The digital process, the technology, now offers us a very accurate methodology to be able to equilibrate our dentures prior to the fabrication. And it's an extremely accurate process, very predictable, and could certainly save a tremendous amount of time. So again, traditionally doing a jaw remount record, taking it in the laboratory, doing it in equilibration, very time consuming, very effective, very good. But if I could trade that into the digital process and the day of insertion, have confidence of inserting the denture, how exciting is that? So another advantage would be at the day of try-in, we're able to take these temporary dentures. This particular denture you're looking at here is a monolithic, and it could be printed or milled denture with a little veneer of pink material just to give it a contrast between teeth and gingiva. But it's a temporary base. But we could allow the patient to take this home because it's not, the teeth aren't going to pop out individually, and there's no danger of the patient choking on denture teeth. And for the discriminating patient, this is a tremendous advantage, so that the patient could not have the 5 minutes of time to look at themselves in a little hand mirror at the chair and an unfamiliar lighting and etc. And so for them to make a a better choice or better decision, it might be better for them to take the trial dentures home with them, so they could view themselves in the comfort of their bathroom mirror, where they see themselves every day, and be able to make some better informed decisions. What a better way to do a try-in, and what a better way not to have to give the patient a disappointing insertion visit where they're said, gee, that's not quite what I would have thought they were going to look like. So this is a nice particular option. And obviously, if the dog gets into the denture and you got to remake the denture, or repeat the process, or remake a second denture for the patient, it's a matter of pressing a new button. You don't have to start from scratch. So having this this electronic memory is a tremendous advantage. And if you discuss this with your patient, you will see their interest in this, and they will look at this as a real lifeline for them to think that there's an electronic memory. So if God forbid something happens to my denture and I lose it, or as I said, the dog gets into it or something, that you could actually remake me another denture, and it's going to be the same denture. It's going to be exactly the same as the denture that you inserted. That's extremely comforting to the patient. And what a wonderful process, and to have and to be able to deliver that to a patient, that promise that we could repeat. It doesn't matter where you are, I'll send them to you. You could be in California or Buffalo or whatever, and we could send you the denture and having it remade and having it to be exactly the same. Wow. Think about that. If you were wearing a denture, how important that might be to you. So let's go through the clinical workflows, and that's really the crux of our program. And again, I guess it's another fair question for you to ask as clinicians. What do I got to change? Do I got to learn a whole new process? Do I got to learn these tinker toys or these things I'm just not familiar with. Is it going to, how much time is this going to take me to, to process and et cetera. So, and it's a fair question to ask, and we'll try to address it with some of the clinical workflows that we've decided to chat on for this particular program. So we're going to concentrate on 4 clinical workflows, and we'll take one at a time. And the first one is going to be probably will be the most familiar potential workflow that you might want to pursue. Again, this is up to the individuals. And we'll refer to this as our traditional wax rim. So if we go through our, basically our traditional process of, the basic 5-appointment denture that we have all been taught pretty much regardless of what school you've gone to, and, preliminary impressions, custom trays, final impressions, wax rims, wax rim bite, back and forth, back and forth. This is our traditional wax rim procedure. And we could use this and up to a point of the wax rim bite registration and stop. And this could be serve as our entry point for the digital denture process. So is it all digital? No, but is it familiar? And is it an easier way for me to transition? It's your call. And I'm just pointing it out that this is a very easy way to transition. We have a number of dental schools who are transitioning and have kind of chosen this particular workflow because they could still teach the traditional procedures, but then they could build on it now with the digital design from this point forward. So let's take a look at what I'm referring to. So here's our traditional wax rim bite. Now, when you do this, the spirit of doing a traditional wax rim is to capture information for the technician, for the laboratory. And so we modify the wax, we mark the wax, we melt the wax, we add to the wax, we do the different things necessary to so this will become a vehicle of information for the laboratory to help to act as a guide for them setting the teeth. So the midline, the labial position, occlusal planes, incisal length, all this basic information really is captured in these rims. So when we go to our particular workflow, we're going to use our wax rims, and instead of mounting this on the articulator, we're going to take this wax rim bite and we're going to scan it. So when we scan it, we're going to end up with a virtual mounted models or casts, and the wax rim information will be preserved, and we could bring this in or take it out as we need to capture the information that is desirable. In this particular case, we're going to use the wax rim to act as a guide for midline and incisal length, our occlusal plane and things. We could tweak this for sure, but at least we have an initial starting point. So the design technician has a starting point in which to set his parameters. I call this like a gun sight, where you could kind of use that as a guide in the positioning of the arch of denture teeth. Remember I said the teeth are going to be a full arch setup. So we bring this whole full arch in, and we at least have a starting point in which to start our process of design and setting of the teeth. So this is a wonderful workflow because it provides the laboratory a ton of information. Obviously, it's information only as good as the information you give. So if you do a decent job with your wax rims, you could expect a replication of that effort in the process of setting the teeth. And from here, we could make a trial denture, or we could go to a final denture. So either one will be capable, it's just a different choice of materials. So this could be this particular workflow for this traditional impressions and wax rim bite. Couple of tips, and this goes to the analog process. This particular tool is referred to as a rim former. You may have, or maybe not have seen this. Very inexpensive tool, but a tool that you should have if you're involved with this wax rim workflow. because it's a very simple tool to apply to, and you can do this chairside or in a laboratory to make adjustments to the wax rim. It melts the wax rim very easily. It's heated over a flame, obviously, and then you apply it. But it's got a hammler fence that rests onto the back of the cast and allows you a pivotal point. And there's a weird relationship between the hammler notches, believe it or not, and your bipupillary line. So using this particular rim former oftentimes gives you a very good occlusal plane as a result of using it. So this is a fascinating tool for a couple of dollars or whatever. And if you're doing this particular traditional technique, it's something you should have. I always, years ago, I used to, when I lectured on traditional analog dentistry, I'd have a show of hands. Does everybody have one of these? And maybe 3 people out of 100 might raise their hand, and I'd yell at the rest of them and say, "You've got to have this. You got to have this. This is a Fox plane. We refer to it as a Biteplane in our toolkit, but it's a way of amplifying the in particular the bipupillary line. Very important to be able to transfer that information to the laboratory, and because otherwise they're guessing. And what a shame it is to have a try-in and your teeth are running, downhill or uphill and cockeyed. And whereas so you should have this little amplification device that will rest on the rim, and you know the technique. And so it's again a very simple tool, and it's certainly in the wax rim workflow, it's an absolute essential. All right, workflow number 2. And this is impressions and bite in dentures, meaning the patient's existing denture. So if we look at this particular workflow, what we're doing is using the patient's existing dentures as a vehicle to take impressions and a bite registration. Very simple process. Now, this could be a very applicable procedure because most patients, I'd say we're in a category at least 70, 80% conservatively, approach your office and have an existing set of dentures. So why not take advantage of it? And sometimes there's a funny thing. Sometimes we feel like we're cheating by doing this. I notice this in schools in particular. It's like, oh, we can't do that. We got to teach from scratch. And I said, yeah, but why? And don't shortchange the value of a patient's existing denture. There's a ton of information here. And in this particular workflow, we'll get through it, and then we'll come back and have a little discussion on it as well. But this is a great opportunity to learn from the patient what they like about their teeth, what they don't like about it, and then we could capture this in our with this new digital technology and be able to apply it. So let's take our simple impressions in the denture, bite registration. We're going to scan it now. 2 different ways it can be scanned. If you send it to the laboratory is going to use a laboratory scan to scan these dentures, but that means they got to hold on to the patient's dentures while this is being done, or you could do it chairside. And I think this is going to be extremely popular. And so most of clinicians nowadays have a intraoral scanner, and it's a relatively simple process that in a maybe the first time it's going to take you 30 minutes, the second time it's going to take you 20 minutes, the third time take you 15 minutes. It's going to it may be down to like 5 minutes or something to do the process. So it's not a particularly time-consuming procedure, and there's a lot of advantages of being able to do it intraorally or chairside. And obviously the major one is you're giving the patients back their denture. If you're taking impressions in their denture, you could scan it and then take the impressions out and give it right back to the patient. That's nice. Another side benefit, though, is infection control, where the impression dentures never leave the operatory. So all the infection control is in the operatory. It's scanned, and everything from this point is electronic. So that information then is electronically sent to the laboratory. So this is, again, evolving technology. If you don't have a chairside scanner at this time? Fine. Well, it goes to the laboratory and you make an arrangement and how this could be done to be scanned. And I have another idea for you too, as we get down here. So let's take the scanned impressions, and now this gets popped up into the computer software. And what we have is, again, mounted models or mounted casts, and we're able to also capture the existing denture information. So that information is going to help us, again, like the wax rims. We could use this as a guide in providing the midline and the occlusal plane and all the information we had talked about before. Now, we do have an opportunity here as well to critique the patient's existing dentures. And you do this with the patient and you make some decisions, and that could be informed to or presented to the laboratory. And I'll show you that particular process. But right now, let's just follow this workflow simply. So we're able to ghost in this information at any time that in the process of selecting and repositioning the teeth. Again, I remind you, the entire arch of teeth that first comes in, and we use this crosshair to help identify the basic positioning of the teeth into the arches, into the inner arch space. And we can make changes and adjusting and whatever, make tweaks, of course. But this is an initial proposal and just trying to get things started, and then we could make some changes from there. And of course, this once we're satisfied with the changes, you could go to the either try-in denture or a final denture. Again, doesn't matter; it's your call. It's just a matter of the choice of materials, but the process of designing is exactly the same. So we have a choice there. So let's go back again. Let's look at our patient's existing denture. And again, let's look at it with a very critical eye. Again, this is a great opportunity because and I always call this this is your first try-in with the patient if they have existing teeth. You try in their existing teeth and have a conversation with the patient. And it's amazing the information that you could obtain. Not only is this interesting information, but I could use it now to help guide my design technician with the information I'm about to receive from my patient and their denture. So you look at the denture, this is an evaluation, which is part of our prescription, which I'll touch on later into the program. But we're going to do a evaluation, and we're going to look at the denture and with a critical eye and check out the midline. So let's say the midline is not where you want it to be with the patient's existing denture. Well, you make notation of that, and we want to, we mark it on the denture because the scanned denture, the mark will carry through, or we write down in a comment, move it 2 millimeters to the patient's left, or whatever it might be. But you make that communication key to success, communication. And but we're using the denture as a vehicle to communicate to the design technician because it's a very tangible way of communicating. And size of length, do you like the length of the teeth? The patient says, well, the upper teeth are okay, but geez, the lower teeth, I can't even see them, So that means I got to lengthen the lower teeth, or I'm going to keep the upper teeth the same. Huge amount of information to give to the laboratory. So this is what the laboratory is going to be working with. He's got a scanned denture here. These are impressions in a denture. And we have the all this denture information. And we basically, as we're positioning the teeth, and we're going to use this information to help guide the initial setting of the teeth. So from incisal length, all the information, lip support, everything we could really utilize. So any comments you make about the patient's existing denture is of value to the laboratory. So what this technology does to you, it forces you to communicate. It really does. It forces you to look at their existing denture. It forces you to make a decision. And it forces you to talk to the patient. Let the patient help you make the decision. As I said, you like the length of the teeth? No, you don't like length. Is your lip too full, too length? you talk to the patient, it is a tremendous amount of information. So I guess as obvious as this seems, but it's worth mentioning. I love this evaluation form because it kind of reminds you. You don't have to use it, but if you do, it's a good reminder of the things you should be looking at and detailing down this particular information. So what's some tips with this particular procedure? Well, taking impressions. This is a different way of taking an impression because you're going to have it's a closed mouth functional impression technique. So it's a little different in the process of taking impressions. But it's a lot of advantages to a closed mouth functional impression. It can certainly it impressions the tissue in a more functional form, and it could actually be a real attribute in the impression procedure. And aha, copy denture. You have the opportunity to work with the laboratory, and there's a lot of ways of doing this. If you don't have a scanner chairside, let's say you do, you have a chairside scanner, as I mentioned, you could scan the patient's existing denture and electronically send this information to the laboratory, and they're going to send you back a duplicate of the denture, probably a printed version, which is a lot the least expensive way of doing it. So so now you've got custom trays with the patient's existing teeth on it. Basically, what a great way to start your process. Why would you deny yourself this opportunity? I like this rather than taking impressions in a patient's existing denture because there's times I want to grind on it. There's times I want to mark it. And there's times I want to put denture adhesive before I take the impressions. And I could do all these things and not worry about, gumming up or distorting the patient's existing denture. So I beg you to consider this particular workflow. Find a way to have the dentures copied. Maybe it means if you don't have the scanner, chairside scanner, then maybe, or you don't want to do that process, maybe have the patient stop by the laboratory, talk to Rob and the people in the laboratory. I'm sure there's a convenient way for the patient to stop in. Takes a few minutes for them to do a scanning of the denture, and patients is on their way. But find a way to consider this particular workflow. I think this should be your number one workflow, go-to workflow. I don't see why I wouldn't want this to be my favorite choice, and in particular for the provider of this process of dentures who doesn't do a lot of it. If you don't do a lot of dentures, it doesn't mean you're a bad dentist or anything, but you don't do a lot of something, you don't get that great at it, And so why not give yourself this head start by having these kind of custom trays right from the get-go to start your process of border molding and et cetera. A tremendous advantage here. I implore you to take this particular workflow as seriously as you can. Next workflow we're going to try to get through here is the immediate denture. And again, we could, on a clinical side, you could do nothing different. Literally take impressions as you normally would, take a bite registration as you normally would, send this to the laboratory. This will get scanned. We got now mounted casts of pre-extracted teeth, and these could be digitally removed. There's an advantage of the laboratory designer to extract the teeth, again, virtually. It's a virtual extraction and a guesstimation of how much ridge to take off. But it's not a guess, because once we get to the designing and positioning of the teeth, we could go backwards and take more off if we need. Can't do that with analog dentistry. So we use this information of the pre-extracted teeth, which have been evaluated, which we're going to talk about in a second, and we could ghost that in at any time to, again, act as a guide. Whatever that data was that your evaluation form tells us, the design technician could use that information in the process of doing the initial proposal of the teeth and getting it started into the right position. And obviously a lot of tweaking, but to have that starting point is absolutely invaluable. And again, we make our final denture. So another process could be if you'd want to use a intraoral scanner and do a chairside intraoral scan, fantastic way to do immediate dentures as well, if you're got the talent or the time and talent and desire of doing this. It's not rocket science, but if you practice at it, you get pretty good at it. So doing a intraoral scan is a great way of doing this process and bite. And then this is again brought to the attention of the software, and the rest of the process is exactly the same. So it just depends which way you want to get there with conventional impressions or doing a intraoral scan. So two good particular options of getting things started. Same form, same information that we're going to try to get as much as we can from the patient's existing teeth. And this, midline and incisal length, these are things, again, it's going to force you to go through this little checklist here and make notations. Um, yes, I want the midline to be the same as it's on a patient, or no, I want it to be 2 millimeters to the left, right, or whatever. Incisal length, yay on the upper, nay on the lower, whatever it might be. You could communicate this by looking at the patient before their teeth are extracted and talking to the patient, getting feedback from the patient. Let them help you make these particular decisions. It's a very, very tangible way to communicate with this new technology. Um, Vertical dimension, very important that you have to make a decision here as well, because I suggest, again, whether you're doing this in a traditional immediate denture or a digital process, you're going to want to make a decision on vertical dimension. In this case, I think you would agree with me. You want to open the vertical to some degree with the interim denture, or maybe you don't. Maybe you want the interim denture to be as familiar to the patient as possible, and you want it at that particular vertical dimension. Your decision, but you've got to reflect that information to the laboratory. So a lot of things to think about and a lot of things to check off. And it's again, I think this is the greatest tip is to use this evaluation form. But a couple more things we'll just chat about. So a couple of tips to look at are taking impressions, a lot of impression options. Well, relatively recently, I've been doing this using a putty material in a pre-formed tray and to take my immediate denture impressions, because the putty material has so much more body than something extruded out of a cartridge. And I'm taking a denture impression. I'm not taking, I don't need detail of the teeth as much as I need a bodied material to help me take a denture impression. And I probably found it hard to do. I like to use that. That's why I used alginate pretty routinely. But I fell on this idea, or somebody told me. I don't know. I don't have any original ideas. Somebody must have mentioned it to try this, and I love it. I love using this material for immediate dentures. And if you want to make it a little bit more accurate, you could trim off some of the excess of the thickness of the material and just put a light body wash, and you could take a very good impression in a relatively very short period of time. Now, obviously, you may say, what if the teeth are loose? Good question, because if they're loose, don't do this technique. Use an alginate material. The alginate that I like is a two-phase material, something that I could inject the light body around the teeth. Helps get a little better rendition of the tooth, but I like the heavy body in the tray, because that's what's going to drive the light body up into the vestibular areas, and you can take a pretty darn nice impression of a dentate impression with this. Lastly is the taking a intraoral scan, and again, it depends on your skill in this particular process, and it's certainly a option, and I think it's going to become the more popular option for sure. And of course, if you do a significant amount of alveolectomy, you may want to suggest having a surgical guide prepared for you as well. Okay, so I am going to look at our time, and it's about where I have to stop time-wise, and it only leaves a few moments for questions. Apologize, I know we started a few minutes later, but I'm going to stop at this particular point, and there will be a part 2 to this program, which will be scheduled. I think maybe Rob could better answer that, because I'm not sure if we really have a time and date. I think it's going to be like in 2 weeks or so. But I hope this has been a good opening. I want you to feel free to ask questions. If you don't ask it today, you could ask it in the next session. But I'll maybe stop here and introduce Jay Cranston and back over to
Thank you, Frank.
these much better looking people than me.
Thank you for the presentation. It was very informative.
You're
I'm going to
welcome,
go
Anna.
ahead and pass it over to Jay for the Q&A session. So Jay, go ahead and take it from here.
All right, thank you. Great job, Dr. Frank, as always. So we do have some questions that have come through. So we have 4, which we should be able to get through pretty quickly. The first question is the denture more brittle if dropped?
Oh, no. One of the nice things with the I'm going to go through the manufacturing options in the next phase. So please come to that, because I think one of the nice aspects of and there's 3 different processing methods that you could choose from, and you could discuss this with Rob in the laboratory when the time comes to making a processed denture. But the nice part is it's polymethylmethacrylate. It's the same material that you've used and it's the same predictability of the materials you use. Depending on which individual process, there will be some differences there. The monolithic process, the Ivosian disc process, will be the strongest denture and least likely to fracture. Of course, unless you take a sledgehammer to it or whatever. But yes, it's going to be familiar characteristics, because it's familiar materials that you've been using for the last 50 years. There's no more brittleness to it. It's not a new material. It's not a unfamiliar chemistry. It's a very familiar chemistry, and that's a very good question to ask.
Great, thank you. Now, it looks like we've got quite a few questions regarding scanning and intraoral scanning. So this next question is, what if we use digital scanner instead of editing? That would be less time consuming.
Meaning that they'll do a intraoral scan and transfer that. Is that the question? I'm trying to get it resolved. Repeat the question. Let me see if I can decipher it better.
What if we used digital scanner instead of editing?
Not quite sure what that means. I assume we're referring to the use of the intraoral process of scanning, and then that's going to be transferred over to the laboratory, which the laboratory is going to do all the order form creation and things. So I don't know if I can answer that, because I'm not sure I understand the question. I apologize. But intraoral scanning chairside is for immediate dentures, or I wonder if we're referring to as a complete denture tissue scan. I'm going to address that in a little bit more detail in the next workflow. And we're going to talk a little bit about the accuracy of tissue, intraoral tissue scanning and things, and see if that can maybe answer those questions. So you two have to come back for the next session.
Okay. The next question. So this person has tried using an iTero scanner with the AI turned off and even the denture powdered. They can't get it to scan the intaglio side completely, not transition over the flange to go from the outer to the inside of the denture. It freezes up and cannot follow the transition. Is it iTero, or is it my machine that has the problem? They've even tried spraying the inside of the denture with foot powder to powder it with no success.
Yeah, I have no experience with iTero, so I can't answer specifically the machine. My guess is it's probably technique, and there is a lot of videos online that could be of tremendous help. I'm going to give a plug here for my good buddy Eric Kukuchka, he's all over the place on YouTube, and he's got a number of videos concerning the technique of doing this. 3Shape does as well, by the way, and they're fairly good. So I'd say jump on YouTube, and you might get at least a little pathway. Each are a little. Eric does it a little bit different than I've seen it demonstrated on 3Shape, but there's just a little technique from going from the intaglio to the outer surface of the denture, and where do you start? There's little differences in technique. So I'd probably say it's technique, and might be nice to just catch yourself a couple of videos to. It's not that challenging. I just did a work with some of my prosthodontic friends online, and we just did it. I sent some slides and some instructions or whatever, and the first time, she scanned the dentures and in a very short period of time. So, but again, that was using a 3Shape scanner. So I can't answer any questions about your scanner though. But check your technique first before you condemn the scanner.
Great, thanks. So another question, at what stage of the workflow would you evaluate phonetics, the F and S sounds, and how would you communicate with the design tech?
Okay. Everything, when you do a try-in, and that would be the communicable stage, and that's where you're going to want to make. And then this next session, I think you've been jumping ahead to it, but we're going to talk about the try-in, because the try-in is going to be the essential element of communication. And the difference in traditional try-in compared to the digital try-in is going to be the traditional try-in is a wax try-in. The digital try-in is going to be what we refer to as a resin try-in. It's going to be a monolithic resin try-in. So it's a little different. And that's going to be probably your greatest personal challenge, just for some of you, because you can't manipulate individual teeth that are set in wax. On the other hand, there's so many other benefits to the resin try-in that you'll find to be a tremendous advantages. If again, I plead with you, if you come back to the next session, we have a whole chapter on the try-in procedure, and that's where the phonetics and things would come into play, and how you would communicate that information. And part of it is to understand the 3Shape software to some degree. You need to have a little bit of understanding so that you could best be able to communicate to the design technician the information that you want to transfer to them. So I think I'm going to defer that to the next. I promise you there's a full chapter on the try-in, and we'll get into a little more detail.
Okay, great. Maybe we've got more questions coming in, but we will have a part 2, and whatever questions we don't finish, we can also answer and send out afterwards. But I'll ask, what are your thoughts on full denture intraoral scans?
Full denture intraoral scan, meaning tissue scanning. I'm assuming.
Yes.
Yeah. It's just funny. I just read an article that is a review of 10 articles and on intraoral scanning and the degree of accuracy and how does it compare and et cetera. And it's somewhat inconclusive in a sense. It didn't. It said that the accuracy is there. It's good accuracy and acceptable accuracy. The trick is going to be technique. As you've had some trouble, one of the individuals mentioned trouble doing the scanning of the denture. Well, doing an intraoral tissue scan is a learning process, and I dare say it will be probably the preferred process in the future. I think the companies are understanding this. The wands will be changing to some degree. The process will be changing. It'll get more compatible for edentulous intraoral scanning. But right now, I'd say the state of the art for intraoral scanning is the maxillary arch. You can be successful scanning the maxillary arch and getting a final impression, final scan. The mandibular arch probably is a much greater challenge because you have a tongue, and it's very hard to keep the tongue retracted as you're trying to get, a decent extension, and it's hard to get a functional rendition of the mucogingival junction, and so the mandibular arch at best you might get a tray, which would still require a functional impression. So that's kind of where the status of the intraoral scanning is at this particular time. And I think it's going to be generational. I hate to sound that way, but I think the younger dentists will probably gravitate towards the intraoral scanning technology, and dinosaurs like myself might, maybe not be as comfortable with the process. But again, I'm going to put this plug in again for Eric Kukuchka, who's a Dentures in Canada. If you haven't heard Eric's programs,
He was
he's got
actually on here.
Pardon me?
He was actually on here.
Eric, I'm giving you a plug. But Eric's done a lot of work in this arena of intraoral scanning and scanning of the denture bases. And as I said, he's got some very, very good online videos, and I think, Rob, I think you could probably give some information on how they could channel into some of Eric's programs.
Great. Well, I think since we are planning a part 2 and we don't want to go too over, we are going to take a stop here. Thank you so much, Dr. Frank. Great job as always. Thank you for answering the questions, and hopefully some of those other questions will get answered in the next part, but I will pass it over to Rob and Medina to close up here.
Well, thank you very much, Jay, and thank you so much, Frank. It was a great webinar and presentation as always, and we look forward to the next one, which will happen in 2 weeks. We'll send everybody out a new invitation. We'll be publishing on different social media platforms. So we plan on seeing that coming out next week for second part of our digital denture workflow, which is mainly clinically oriented, and will show the more advanced talking about the Nathometer CAD, the UTS CAD, and other clinical options, for digital denture solutions. So thank you very much for attending.
Thank you, everybody, and be sure to check out our website for recorded webinars, microdental.com/recorded webinars for recording of this webinar in 1 week from today. In addition to, please be sure to complete the